Hi, very good morning. I'm Dr. Janak Patel. I'm a general physician. I'm not an endocrinologist. Today, I'll be talking about one of the endocrine disorders which is related to ADH hormone. We call it diabetes insipidus. So, diabetes insipidus is because of lack of ADH hormone, or we also called as water diabetes. So, we'll be discussing under definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. We'll be discussing under these headings. Diabetes is derived from Greek and Latin word that is to pass through, and insipidus means having no flavor. So diabetes insipidus is a clinical condition due to deficiency of ADH hormone or kidney becomes resistant to effect of ADH. That we call as a nephrogenic diabetes insipidus. So we divide into two groups, central or we call neurogenic or we call nephrogenic. This diabetes insipidus may be for a short period, we call transient, or maybe permanent. So these are the two common terminology which are being utilized, central variety or we call neurogenic variety and nephrogenic variety. And as far as the period is concerned, transient and permanent. So diabetes insipidus is go through. Diabetes means insipidus means without taste, and when we say mellitus means sweet urine. So insipidus involves the passing of urine that is tasteless because of relatively low sodium content. We already told you that there are two varieties. One, because of decreased ADH production, we call central or neurogenic, and where the nephron, that is distal convoluted tubule, becomes refractory. Tubular cells become refractory to action of ADH, then we call that as nephrogenic variety. There are other two varieties which are also being labeled, that is GESTAGENIC, which is caused by deficiency of ADH hormone during pregnancy, and there is another variety we call DIPSOGENIC, which is because of a psychological disorders that is called primary polydipsia, that is abnormal thirst and excessive intake of liquid will produce a condition where you will get dipsogenic diabetes insipidus. Etiology wise, we divide into pituitary or we call cranial or we call central or we call neurogenic or nephrogenic. In nephrogenic it is genetic and acquired. Gestagenic and dipsogenic or we call primary polydipsia. It may be transient, it may be permanent. As far as etiology of central diabetes insipidus is concerned, or we call neurogenic diabetes insipidus is concerned, 30% of the cases are idiopathic and 30% of the cases are because of supracellular tumor, which are the tumors basically of hypothalamus or because of posterior pituitary. Infection like encephalitis, tuberculosis, tubercular meningitis, non-infectious granuloma like sarcoidosis, and there is one disorder called as a Hand-Schuller Christian disease, traumatic injury, particularly basal fracture skull, leukemias, etc. These are some of the causes for central diabetes. Other group includes autoimmune disorders, particularly associated with thyroiditis, familial variety, which are sex-linked inherited disorders, which can be diadomo, called as a Wolfram syndrome or called DIAD-MOD, that is DI for diabetes insipidus, DM for diabetes mellitus, O for optic atrophy, and D for what we call as a deafness. So diabetes insipidus, diabetes mellitus, optic atrophy and deafness. So that is called Wolfram syndrome or also called as a DIAD mode. syndrome. Some of the drugs can also produce decreased production of ADH and results into diabetes insipidus, like ethanol, diphenyl hydroxide sodium. Anticonvulsant drugs also inhibits ADH secretion. Lithium is another drug, and democycline. And democycline inhibits ADH action on kidney. This is a compound which belongs to tetracycline group, and hence this is also utilized in a person with SIDH, where you want to decrease the action of ADH on kidney. So this is one of the treatment in case of SIDH. Nephrogenic variety can be primary or can be secondary. Primary means because of the idiopathic cause or sex-linked recessive disorder, which is vasopressin receptor gene disorders. It is an autosomal recessive where aquaporin genes are defective. While in a secondary variety, or we call as an acquired variety, the commonest causes are chronic pyelonephritis, hypokalemia, hypercalcemia, sickle cell disease, and protein deprivation. So these are some of the conditions in nephrogenic variety. Rare condition like amyloidosis, chronic renal failure, obstructive uropathy, polycystic kidney, Sjogren syndrome, drugs like lithium, colchicine, fluoride, cidofovir, democycline, methiofluorine, etc. These are all the different drugs. Out of this, lithium is very common and colchicine is the another one. They are quite common. And democycline will also produce. This is slide showing you central variety, nephrogenic variety, which can be divided into primary and secondary. Nephrogenic can be also divided into primary and secondary. So in a nephrogenic variety, primary can be genetic, and in secondary, probably because of chronic renal disorders, drug-induced osmotic diuresis, systemic disorders, and particularly in a pregnancy, we call as gestagenic. And there is one odd variety we call as a dipsogenic. While in a hypothalamic variety, primary, which is a genetic variety, we call Wolfram syndromes, which is an autosomal dominant or autosomal recessive, or it can be idiopathic. And in secondary variety, very commonly following a head injury, transcranial surgery or transsphenoidal surgery, particularly in a person having a craniopharyngioma or secondary metastasis or pituitary microadenomas or macroadenomas, and it can be also there in a case pregnancy associated with vasopressinase. So these are all the different conditions which can end up with a diabetes insipidus. Other groups in central variety which produces secondary or we call acquired group is inflammatory like granuloma, sarcoidosis, or Guillain-Barré syndromes, vascular like aneurysm, infarct, Sehan syndromes, sickle cell disease, etc. These are all rare conditions, but they do come across. So these are the etiology for genetic variety, chromosomal, sex-linked disorders, Wolfram syndromes, where you get diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. In a congenital variety, you get lot of other conditions. And in acquired, head trauma, neoplasm like craniopharyngioma particularly, or pituitary adenoma, granulomas, infections like meningitis, tubercular meningitis, autoimmune disorders, toxins, vascular like Sehan syndromes, etc. And among nephrogenic variety, sex-linked or it is autosomal recessive. Among acquired, most common drug, lithium, is very, very common. Metabolic disorders, hypercalcemia, hypokalemia, vascular disorders like sickle cell, granulomas, certain neoplasm, polycystic kidney, obstructive uropathy, all those conditions. Now there are two basic pathophysiology. In a central variety, the production of ADH hormone decreases, hence the action of ADH hormone is reduced, and it will end up with decreased reabsorption of water, and there will be polyuria, polydipsia. because of hypovolemia. So fluid imbalance will take place, renal reabsorption becomes less, and person will develop polyuria and polydipsia. So that will be the common thing in a person with a central variety or neurogenic variety. And person is still vasopressin sensitive. So if you give a vasopressin, the condition will reverse back. So person will have an improvement in the symptoms and signs. While in a nephrogenic variety, there is a normal production of ADH hormone, but there is no effect on renal tubules, and hence there is no reabsorption of water. And this is we call as a vasopressin resistance. While in a dipsogenic variety, it is a suppression of ADH because of excessive intake, secondary defects because of excessive thirst, and person takes lot of water, fluid intake is increased, and this is because of psychogenic cause. So normally what we say that whenever the person who gets secretion of ADH hormone, that ADH hormones acts on a distal convoluted tubule, and by acting at the distal convoluted tubule, it increases reabsorption of water, and by increasing the reabsorption of water, water is retained back. While in a person who has got a diabetes insipidus, the urinary expulsion, urine is expelled from the body excessive because the water is not reabsorbed, and as the water is not reabsorbed, the person has got increased urine output, which is a very dilute urine, so he gets polyuria. Because there is a loss of water, person develops hypovolemia, and that stimulates hypothalamus to increase thirst, so person gets polydipsia. Because of polyuria, person is also having nocturia. If water is not replaced, person will develop hypovolemia, hypotension, and shock stage. Along with this, there are certain laboratory findings which are very much in suggestive of diabetes insipidus. Sodium becomes more because the water is lost from the blood. So osmolality also increases. So plasma osmolality is more than 285. Relatively, person develops hypernatremia. Urine osmolality is markedly reduced. Urine sodium is low. Urine specific gravity is very close to normal water content, and urine output becomes more than 3 ml per kilogram per hour. So if a person is weighing 70 kg, it will be 210 ml per hour. So if you calculate in 24 hours, it will be almost more than 5 liter. So it is, we always say, it will be more than 4 to 5 liter per day. And if water is not replaced, person will develop hypotension, hypovolemic hypertension, and then person can go even into a shock stage. So in a clinical feature, the most common is polydipsia and polyuria. And because of polyuria, person will develop nocturia. Secondary to nocturia, person can have, if fluid is not replaced, symptom signs because of hypovolemic hypotension. And if severe enough, even a person can develop shock stage. So polyuria, polydipsia, increased thirst, nocturia, nocturnal enuresis, hypernatremic dehydration, and because of hypernatremia, person will have a CNS symptoms like altered behavior, irritability, seizures, and person can even become comatose. Person along with hypernatremia and dehydration will develop anorexia, constipation, hypothermia, lack of sweating, and symptoms of underlying cause. Whatever is the etiology of diabetes insipidus, person might have symptom signs of that. We have already told you serum sodium will be more relatively because of water loss, increase in serum osmolality. Urine specific gravity is very, very dilute. Urinary sodium is normal or slightly increased. Urine osmolality is markedly reduced. And these all findings are in favor of what we call as diabetes insipidus. And if you calculate the urine volume, the person will be passing a very dilute urine, and large quantity. It is we say that the 3 ml per kilogram per hour. Particularly in a person where a person gets a damage to pituitary gland stalk transection, means in a post-surgical case, wherever the person has undergone a surgery and there is a transection of a pituitary stalk, you will get 3 stages: transient variety, permanent variety, and triphasic variety. You will have 3 different types. In a triphasic variety, initially you will have a polyuria, which will be for 1 to 5 days. There will be inhibition of ADH release due to hypothalamic dysfunction. After 5 days, for 6 to 11 days, antidiuretic phase, where slow release of stored hormone is there from posterior pituitary, and later on person develops permanent central diabetes insipidus because there is no longer manufacture of ADH hormone by hypothalamus, and there will be no storage in a posterior pituitary. Hence, initial polyuria followed by antidiuretic phase, temporary, and then person goes into what we call as a permanent central diabetes insipidus. This is the classical triphasic response in a person post-surgical variety. Now, this is the main difference between central and nephrogenic. It is very important because good number of time clinically also you can make out the difference between the two. In central variety, there is a lack of ADH hormone, while in a nephrogenic variety, there is an adequate production of an ADH hormone, but the structure, functional defect in a distal convoluted tubule, structural or functional defect in a distal convoluted tubule, or what we call as the ADH receptors. Central variety, good number of times there is a congenital defect in a hypothalamus or pituitary, or because of an acquired conditions, you get decreased production of an ADH hormone. While in a case of a nephrogenic variety, it can be congenital defect or can be an acquired defect. The commonest causes in diabetes insipidus as far as acquired group is concerned, trauma, infections, etc. of a pituitary or of a hypothalamus. While here, it is a trauma or disease of a kidney. The symptoms almost remain same in both variety, that is polyuria, polydipsia, electrolyte imbalance, dehydration, low level of ADH hormones, urinary, low specific gravity, all those are nearly same. But in this particular nephrogenic variety, ADH level may be close to normal. Diagnosis to rule out this is rule out the other causes, do investigate radiology or radiooptic study of pituitary and hypothalamus. You can do water deprivation test or what we call as ADH trial. You can give vasopressin trial in case of central diabetes insipidus. While in this case, you have to rule out central diabetes insipidus, and then you can think in a term of a nephrogenic variety. Treatment as far as the central diabetes insipidus is concerned, replacement therapy we call desmopressin. While here, you give a drug which will increase the sensitivity of the distal convoluted tubule like oral chlorothiazide, chlorpropamide, non-steroidal anti-inflammatory drug, restrict salts, etc. will give you a little benefits. Prognosis wise, usually this is not life-threatening if the fluid replacement intake, etc. is being maintained. While in a case of a nephrogenic variety, usually congenital is chronic, while acquired, depending upon the treatment and response, it will be variable. If you investigate, urine osmolality is low in both variety. Plasma osmolality is also low in both variety. Post water deprivation test in central variety, it will remain low. In nephrogenic also it will remain low. And plasma osmolality in a water deprivation test will remain high in both. Post water deprivation test, and if you try to do a ADH hormone level, serum, arginine, vasopressin level, it will be low in central variety, while in a nephrogenic variety, it will become high. Response to desmopressin will be very good, while here there will be hardly any response. So we call poor response. So these two are the main important to differentiate between the two varieties, that is central variety and nephrogenic variety. MRI, if you do for a posterior pituitary, you will see that the pituitary is being damaged, posterior pituitary damage, invariably you will get, or there is an absence of posterior pituitary gland, while here the posterior pituitary gland will be normal. Long-term prognosis is usually good in central variety, that is congenital, and among acquired depends upon the etiology, while in a case of a nephrogenic variety will depend upon the response to the treatment. In a congenital variety of a nephrogenic, usually the person is short stature, mentally retarded, very common. This is a difference between central nephrogenic and psychogenic. In psychogenic variety, to differentiate between central and nephrogenic variety, if you ask the person to restrict water intake, deprivation test, immediately the kidney will start concentrating, the urine specific gravity will increase, and that goes in favor of a psychogenic variety. As far as the investigation is concerned, history, examinations, water deprivation test, vasopressin challenge test, these two are the most important. So we'll be showing you how water deprivation test and vasopressin challenge test differentiate central, nephrogenic and dipsogenic. 24-hour urine sample and look for specific gravity, sodium, etc. And plasma in blood, look for sodium, look for plasma osmolality and ADH hormone level. For pituitary and hypothalamus, MRI study is helpful to find out pituitary tumor, hypothalamic tumors and atrophy of pituitary gland. So whenever a person comes to you, look at the plasma sodium level. If plasma sodium level is more than 143, you can think in terms of a diabetes insipidus. Plasma osmolality will be elevated, more than 295. Urine osmolality will be less than plasma osmolality. And morning urine osmolality may be suggestive in early infancy. Straightforward, you can go for what we call as a vasopressin or we call as a desmopressin test. As soon as you give a desmopressin, urine osmolality will increase and it will become more than plasma osmolality. So that is suggestive, meaning when you give an ADH hormone from outside, that is desmopressin from outside, urine will start getting concentrated because water is reabsorbed because of ADH hormone will now have an effect on the kidney and plasma osmolality will reduce while urine osmolality will start increasing. So urine osmolality will become more than plasma osmolality. It is in favor of straightforward central diabetes insipidus. And if there is no change, urine osmolality remains less than that of plasma and there is no decrease in urine output and urine specific gravity remains same, it is more in favor of nephrogenic diabetes insipidus. So if a plasma osmolality is less than 143, plasma sodium is less than 143, plasma osmolality is less, urine osmolality is less than plasma osmolality, and now you go for a water deprivation test. If a person is having water deprivation for a longer period, say for 24 hours, in case of a primary polydipsia, immediately the urine will start getting concentrated. In case of a nephrogenic diabetes insipidus, as well as in case of a central diabetes insipidus, usually there will be no more effect. You have to monitor blood volume, plasma sodium, plasma osmolality, urine osmolality and plasma ADH level. You will have to do all these things. So you try to monitor and you can interrupt if there is a loss of blood volume that is more than 3 to 5% and plasma sodium becomes more than 143. Stop test in between. If a plasma osmolality becomes more than 295, again stop. urine osmolality starts increasing and becomes normal, or ABP measurements after interruption, also whenever available, try to do that. Now, what will be the finding? In a normal person, usually urine osmolality will start becoming more than plasma osmolality. But if urine osmolality still remains less than plasma, go for what we call as the ADH test or desmopressin test. If urine osmolality starts become more than plasma and ABP levels are less in blood, meaning it is a partial diabetes insipidus, or if ABP level becomes normal, then primary polydipsia, or you ask him to restrict water, and that is because of a water restriction. So you try to differentiate between central, nephrogenic and primary polydipsia by following this particular what we call as algorithms. This is the difference between SIDH, diabetes insipidus, and what we call as a central salt wasting syndrome. So these are the three conditions which are very closely differential diagnosis. So try to, in diabetes insipidus you will get hypernatremia, in SIDH and salt wasting you will get hyponatremia. I will not be discussing in more detail because this is very difficult to differentiate these two, but try to differentiate SIDH from diabetes insipidus, and that is very easy by doing a serum sodium, urinary sodium, serum osmolality, because serum osmolality in diabetes insipidus is always more, while in SIDH it is less, and serum sodium is also less because plasma osmolality starts reducing. So try to do that. So in SIDH, the plasma osmolality, or we call serum osmolality, is less than 270, while in a diabetes insipidus it is more, serum sodium is more, and urinary osmolality is markedly reduced in diabetes insipidus while it is very high or it is increased in case of SIDH. So this 4 investigations helps you a lot. And urine output usually in SIDH will be oliguria, while in case of diabetes insipidus it will be polyuria. So if you look at this, all these things, it will be very helpful. What happens because of that? Here there is a water retention. Because of water retention, blood pressure is maintained. Central venous pressure is maintained, or sometimes even the central venous pressure is slightly high. There is no dehydration, and due to water loading, little amount of water loading, there is relative hyponatremia. While in case of diabetes insipidus, central venous pressure is usually low. Blood pressure, if water is not replaced, hypotension. Fluid status wise, usually there will be always dehydration, hypovolemic dehydration, and along with that, person will have a symptom signs of hypernatremia. In SIDH, ADH hormone level is very high, while in case of diabetes insipidus, the ADH hormone level is low. Because this I will not repeat in SIDH. I will put the slide, but I will not be repeating. And as far as the treatment is concerned, in SIDH, fluid restriction, give sodium from outside to manage hyponatremia, and to decrease ADH production, you give democycline. So this is one very important thing which will help you to reduce ADH level. While in case of diabetes insipidus, plenty of water, desmopressin from outside, and in variety of hydrochlorothiazide in case of a nephrogenic variety. These are the treatment, and we'll be going in little more detail in treatment part of diabetes insipidus. We have already told you water deprivation test and what we call as a vasopressin stimulation test. In a water deprivation test, person is asked to stop water for at least minimum 12 to 24 hours, depending upon the conditions. During that particular time, look at the weight, look at the urine specific gravity, osmolality, urine volume, as well as look at the plasma sodium, plasma osmolality. So if you deprive a person of water, and if urine specific gravity start increasing and urine osmolality becomes more than 600, stop the test. If body weight is lost still, signs of volume depletion is still present, also stop the test and check for ADH hormone. Now, give desmopressin. And if you give a desmopressin, now urine output decreases, urine specific gravity increases, urine osmolality increases. It is straightforward in favor of what we call as a central diabetes insipidus. But if urine osmolality remains less, no increase in urine specific gravity, no increase in urine osmolality, it is in favor of nephrogenic diabetes insipidus. And if there is increase in urine osmolality after deprivation test, then it is also in favor of, in a water deprivation test also, there will be increase in urine specific gravity and urine osmolality. It is in favor of psychogenic polydipsia. So try to identify this by doing a simple test. And this is a simple thing what is being mentioned. After deprivation, if urine specific gravity is less than 300, then central diabetes insipidus, because it has not changed. In a nephrogenic also it does not change. In a primary polydipsia, it will become more than 750. But if it is more than 300 but less than 750, it is partial diabetes insipidus, where a little amount of replacement of a desmopressin from outside will improve the condition. In a vasopressin challenge test, you give a 5 unit of vasopressin by nasal spray, and if the urine specific gravity starts increasing, it is in favor of what we call as a central diabetes insipidus. So look at the urine specific gravity and osmolality. If it does not increase, it remains less only, then it is primary or secondary diabetes insipidus, or we call central diabetes insipidus. And also in case of nephrogenic also, there will be no improvement in diabetes insipidus. So we give therapeutic trial. So if you give a therapeutic trial, either by a nasal spray for 2 to 4 days, you will see in a central diabetes insipidus there is an improvement in polyuria, polydipsia, and person remains normal. So sodium remains normal. In nephrogenic, there will be no response. In a primary polydipsia, there will be progressive dilution of hyponatremia. And this will be a very easy way to differentiate between the three: central, nephrogenic, and psychogenic polydipsia. Now there is always one interference by other endocrine hormones, like low level of glucocorticoids and thyroid hormone will reduce the fluid delivery to the kidney and thus also reduces urine flow. And this may interfere with interpretation in when you are doing differential diagnosis of diabetes insipidus. So you have to keep it in mind regarding glucocorticoid and thyroid hormone. So even if the diabetes insipidus is present, glucocorticoid and thyroid deficiency may mask polyuria. So try to rule out this first. So do the level of glucocorticoid and thyroid hormone and then do the test for diabetes insipidus. There is another test which is being done in some of the patients. That is, you give a hypotonic infusion. In central diabetes insipidus, undetectable ADH hormone during a progressive hyperosmolar state or value falls to a right to a normogram relating ADH hormone to plasma osmolality when you give a hypotonic saline. While in the case of a nephrogenic diabetes insipidus, ADH inappropriately is high for plasma osmolality. While in case of a psychogenic polydipsia, the ADH hormone to plasma osmolality remains normal. And this is the response with a hypertonic saline. Hypertonic saline. So when you give a hypertonic saline, the plasma osmolality will be this and ADH hormone production will be this way. So depending upon which disease it is, so this is in a nephrogenic diabetes insipidus, This is in a central diabetes insipidus, dipsogenic diabetes insipidus, and this is HDI, that is central diabetes insipidus. MRI can help you out because if there is nothing in a pituitary fossa, it is because of the destruction of a pituitary gland. You have to differentiate between all those four variety, that is neurogenic or central we call, nephrogenic variety, gestagenic because this will occur only during pregnancy, and dipsogenic primary polydipsia, whether it is transient or whether it is permanent. So always differentiate. Also polyuria from osmotic diuresis, excess of fluid which is being given quite frequently, diuretic use, you should try to differentiate. Sometime a recovery phase of acute renal failure in a primary polydipsia, and sometime when you relieve the obstruction in an obstructive uropathy, it can be followed by a polyuria for a short period. Always keep it in mind. This could be some of the condition which can produce polyuria. So wait for a while, investigate properly and make the diagnosis. We have already told you in a post-operative person who has been operated on a hypothalamus or on a pituitary gland, person do develop a diabetes insipidus in a triphasic response. So do keep it in mind. And this is the way you approach in that particular person. As far as management is concerned, in nephrogenic diabetes insipidus, neurogenic diabetes insipidus, gestagenic and dipsogenic, general principle is maintain water balance. Try to correct the water balance and see that the rate of correction should be such that person do not develop a hyponatremia or hypernatremia. Appropriate fluid replacement should be done. Look at the volume, look at the potassium deficit also simultaneously and correct that. So simultaneous correction of the potassium is also necessary. In a variety of a central diabetes insipidus, long-acting vasopressin analogs, that is we call desmopressin, either in the form of a nasal spray can be utilized, or there is another compound called as a idiopressin, which can be utilized again in the form of a spray, and this will correct central diabetes insipidus. While parenteral injections of minerin can be utilized depending upon the requirement. While in a nephrogenic variety, usually hydrochlorothiazide is given in a form of 25 milligram per day, which will help, and this is called as a water pills, which will help nephrogenic diabetes insipidus to improve. And second drug which is utilized is non-steroidal anti-inflammatory drug, and among that ibuprofen is a drug of choice, 200 milligram per day with low salt diet. So this is a treatment in a nephrogenic diabetes insipidus. While in a dipsogenic variety, clonazepam is utilized, usually in a form of 100 milligram per day, which may reduce polydipsia in a patient with refractory schizophrenia on other dopamine agonist. So this is one drug of choice in a person with dipsogenic variety. This is what we call as a treatment in case of a nephrogenic. We already discussed. Stop any causative drugs which is responsible for nephrogenic variety. Maintain water balance, maintain electrolyte balance, restrict sodium intake, give thiazides, stimulate sodium and water reabsorption from proximal convoluted tubule, decrease water delivery to the distal convoluted tubule. You can use thiazide diuretics or amiloride. You can use indomethacin also or ibuprofen, and in some cases even desmopressin may be of some help. We already discussed regarding a central diabetes insipidus. Pitresin is a drug of choice. Synthetic preparations are there. By and large, now desmopressin is a drug of choice which is being utilized in the form of a nasal spray. So pitresin use, desmopressin use. This is in detail. Primary polydipsia, Main important is restrict fluid intake is the main treatment in primary polydipsia. Diabetes insipidus during gestational usually involves the use of desmopressin by means of a nasal inhalers until the pregnancy is over. May or may not require continuously.